Ladies and gentlemen, good morning. It's my great pleasure to welcome all of you to participate in today's webinar. My name is Mark Wu, the Hematology Specialist and Mandarin IVD Division for Middle East and African market. As everyone knows, blood testing has become the necessary item of the laboratory test. And what is the current development trend of the blood testing technology and how to achieve more reliable detection in hematology, especially for abnormal blood cells? With these questions in mind, today we invite the experts from Nigeria and China to share and discuss these issues with us together. I hope you can enjoy our webinar today. Today, we are very honored to invite Dr. Akara to be the host of our webinar. He is the senior laboratory expert from Nigeria and the former Secretary General, West African Postgraduate College of Medical Laboratory Science. So now, let's warmly welcome Dr. Akara to give the opening speech. Welcome, Dr. Akara. Welcome, Dr. Akara, to give us the opening speech.
Thank you very much indeed, Mark. It's my pleasure and privilege to play host to this important webinar. The topic of our webinar is technology trends and immature cells detection in hematology. And the agenda is as follows. As displayed on the screen, we will be going through this agenda in the next 1.5 hours. Dr. Anne Abiola Obena will be speaking to us on autoanalyzer, recent trends and applications in hematology. Dr. Anne Abiola is a consultant hematologist, a pathologist with the College of Medicine, University of Lagos, and a consultant to the Lagos University Teaching Hospital in the Department of Hematology and Blood Transfusion. She is a renowned expert in hematology with many years of experience in practice. After her presentation, we will also have Dr. Hongchun Wang, who will be presenting on the application of managing immature granulocytes in clinical practice. Following his own presentation, we will have Dr. Henry Huan, who will be presenting on clinical research in hematology of Mindray. Hematology of Mindray IVD division. And of course, last but not the least, Mr. Kelechi Ekwonwa, a clinical application specialist, a medical lab scientist, will be presenting on Mindray high-end hematology solutions. So I welcome you to pay close attention and follow in the presentations. We would have 15 minutes for question and answers at the end of the presentations. Whatever questions you have, you can post in the chat box. We'll take note of them and call the attention of the speakers at the end to provide.
Just your camera is getting ready.
You're most welcome. It's a great pleasure having you around. So let me have the privilege of inviting Dr. Anne Abiola Obena to present on autoanalyzer, recent trends and applications in hematology. Dr. Obena, you're most welcome.
Good morning, everyone. It's a privilege to be here this morning.
and I will just share my screen and we'll be starting immediately. Okay, so this morning, I'll be talking to us about autoanalyzers, recent trends and application in hematology. I want to say thank you to Mindre for inviting me to give this talk. So first of all, this is just to remind us what the hematoanalyzers are to us in hematology. Right. So they are specialized machines, and the key thing that they do is count and identify. And they do these two things at high speed and with great accuracy. And so why are we talking about autoanalyzers today? The first reason is that we can do a lot more tests with less labor and at a shorter turnaround time. It also reduces the risk of transcription error. We are less dependent on paperwork, and all this cumulates in reproducibility and precision. So what is our objective today? We have two major objectives. One is to understand the technological advances that have evolved and why these advances. And the second is to look at the clinical use of the parameters that we obtain from the hematology autoanalyzers. So we'll start with this brief history, which will actually tell us what has happened over the few years. So early in the 1600s, the microscope was discovered. And with the discovery of the microscope came the discovery of red cells and many things. But the Nuba chamber, as small as it is, actually has grown together with hematology, if I will say. And for a long time, this is what we had, both to describe cells and to also determine the count of cells. But I'm sure we will all agree with me that this was very cumbersome. We could do fewer tests taking a longer time. It was prone to error. It was highly subjective on whoever is running the test. But in 1956, Wallace and Joseph Coulter discovered the electrical impedance technique. And this has revolutionized hematology as we see it today, because with it came the ability to count particles, not only cells, at a faster rate and with more accuracy. Subsequently was also, the development of the light scatter system with the emergence of flow cytometer, the ability for cells to be streamlined, and then the discovery that when laser light beams are directed at these cells, the scatter that they produce can give us understanding of the morphology of the cells, the internal granularity and everything, complexity of cells. Subsequently, we have the the cytochemistry came in, which also now added, because when we were at the Coulter, as we will see, we had a limitation, which means we could only have a 3-pack differentials. But with the other cytochemical counters, the VC technology and the SF cube technology, we're able to have more than 3-pack differentials. Some of them can give 5, some of them can give 7. So we'll quickly look at some of this in details and understand why this came about. So let's look at the electrical impedance. This is actually based on 2 principles. One, that particles which are non-conductive, if they are placed in a milieu that can conduct electricity, we can actually see the impact of those cells on the electrical flow. So let's look at this picture, for instance. We can see that there's an external electrode. There's an external electrode and an internal electrode. And these particles could be our red blood cells. So as they pass through this electric current, there is an impedance, which is counted. So with each cell that passes through, there's an impedance. And also the size of the cells will also determine the aptitude of the pulses that are generated, also tells us something about the cell. So with this came the ability to count cells and to do a 3-pack differential. But it had a limitation. It couldn't tell us about the shape of the cells. It couldn't tell us about the color of the cells. It couldn't tell us about the density of the cells. So all we could do was count cells. Another limitation was that the cells were counted based on their numbers, And so if we looked at a graph, for instance, you have platelets, you have red cells, and then you have the white cell mixed population. This mixed population consisted of many other cells which are neither neutrophils or lymphocytes. And this was one major limitation that the coulters that use just the electrical impedance had. This led to the question, how can we do things better? How can we improve on differential counts in WBC? And one of the technologies that came up after that was the radio frequency. Now, the difference between the radio frequencies that we were using alternate current instead of a direct current, and the alternate current had the ability to short circuit the bilipid membrane, which means it can now give us a picture of the internal structures of the cells, vis-a-vis the nuclear volume of each of the cells. So that gave an improvement because now we could now have a packed cell, 5 packed cell differential. We also have the cytochemistry. The cytochemistry also came in. This also improved on the electric impedance because the cells were now stained. And because of the staining of the cells, we could also now have a 5 packed differential. Now, the flow cytometer was also a very important technology that came to be. And its importance is because of its ability to allow a single cell to pass through the light detector area, region at a time. And so when the light passes through the cells, it actually scatters the cells. And the different angle of scatter actually tells us a lot about the cell that has passed through the light detector regions. And all the scatter rays that are detected are now picked by the different kind of detectors and then interpreted. Now, we still had some limitations with this. And then the fluorescent dyes came. And these dyes were able to stain the nucleic particles and other cell organelles. And therefore, we could further differentiate platelets, nucleated red blood cells, and reticulocyte counts. Now, the two major technologies that have revolutionized what we see now are also highly dependent on the optical scatter. So when we talk about the light scatter can either be a diffraction, which means we have the bending of light across corners, or refraction or reflection. And then the angle at which the light scatters tells us a lot. Like a forward scatter, for instance, is related to the volume of a cell. When we have an high angle scatter, it describes the refractive index and tells us what is the cellular component. So this just made us to know that different angles of scatter gives us different information about the cell. I think my network, I can't seem to move to the next slide, but I will continue. So in the next slide, we should actually be talking about trying to look at how the VCS technique, which is the volume, conductivity, and scatter technique, which came up in the 19,000s. Now, the volume actually still works on the direct impedance. I hope I am able to move my cursor very soon. Works on the electric impedance and tells us the volume of the cell. The C talks about conductivity and actually is based on the radio frequency that we mentioned earlier. So it's able to tell us about the cell, the nuclear volume, and also gives us an idea about the internal organs. Then we have the light scatter, which further tells us about granularity of the cells. And we are now able to detect. Now, the advantage that this case brought out is that we could now differentiate different levels of white cells, even the blast. We could also differentiate atypical cells. We could also differentiate nucleated red blood cells. But we still had some limitations. And those limitations, I am sorry, I think I should stop and start because you can't see and I can't move. So a new technology was now developed, and that is this SF cube technique. Okay, so thank you. So we're into this technology. The two technologies actually are 3D technologies because they give us more information and we can have the 5 parts. Now, I've quickly told us about the VCD. We have the volume, which actually depends on direct current passing through. And so we can see that it actually goes around the whole cells and can tell us the size of the cell. Conductivity, as I told you, is based on the radio frequency, and it uses the alternate current. And it tells us about the nuclear volume and the chemical constituents. Then we have the scatter, which tells us about the shape, the nuclear lobe. So with all this information simultaneously analyzed, it gives a 3D picture, which helped us to detect much more cells, as we will see. So now we're able to now differentiate between the monoblasts, the myeloblasts, immature cells, band cells, nucleated cells, platelet counts, and even malaria parasites. However, there were still some limitations of this technology. One of them was the ability to have an accurate platelet count and to be able to give a differential count that included nucleated red blood cell right from the beginning, so we didn't have to be making a correction. And with that came the SF cube technology, where the S stands for the laser scatter. And this tells us about the cellular complexity. So we see light coming in, and there is a side scatter, which is picked by a particular probe. Fluorescent dyes are also applied to these cells. And so there's also fluorescence signals. And these fluorescence signals actually pick both RNA and DNA. The ability to pick RNA actually, the ability to pick the RNA actually added an advantage, which is that we could now pick reticulocytes, which are young cells, and nucleated red cells could be differentiated and counted along the differential from the word go. And then we now have the forward light scatter, and that is where the SFF or the SF cube technology came into being. So these are the advantage. We could enumerate nucleated red blood cells, which are very important, especially in the neonates. Basophils could be differentiated from immature granulocytes and atypical lymphocytes. And also we could differentiate platelet clumps. You know, this is one of the disadvantages that we have had from many of the autoanalyzers, in that when we have the EDTA platelet aggregation that occurs, we usually have a pseudo thrombocytopenia. With this technology, using the optical platelet pathway of this technology, it is now possible to avoid the impact of the EDTA. And so that is how technology has improved, and the hemoanalyzer has improved in its ability to deliver in the hematology lab. So now we're going to be looking at these parameters that are generated. How useful are they? Now, the first thing we'll look at are the red cell parameters. I'm sure if we had the ability to tell us how many we use, many people will be using probably just the red cell count, the PCV, and maybe MCV, MCH. But we've found out that these autoanalyzers actually generate more than that. So the question before us today is, how do we approach this multitude of parameters? Now, it will depend whether we're clinicians or laboratorians. A laboratorian is aiming to prove that the quality of the result that he's sending out is good. And therefore, he wants to make sure that there is no error. One of the easiest ways to look at it is to look at what the MCHC is. If it is extremely elevated, we should actually look for other causes, which might not necessarily mean that the cell itself, the MCH itself, is increased. But we'll focus today on the clinician pathway, assuming that the results have been quality controlled. Now, one of the first things that a clinician can do is to look at the HB, that is the hemoglobin level. If it is low, he wants to find out what is the cause of this anemia. And the second thing will now be to look at the mean cell volume. Now, the mean cell volume is generated automatically, unlike when we do our manual that we count. So we look at the mean cell volume. If the mean cell volume is low, we're going to be thinking of a microcytic anemia. If it is high, we're going to be thinking of a macrocytic anemia. Now, the next parameter we might look at is the red cell distribution width. This tells us the variation in size of the red cells. Many times this is overlooked, but this gives us a lot of information, because when we have a high red cell distribution width in the presence of microcytosis or a low MCV, we will be thinking of things like nutritional deficiency, probably iron deficiency anemia, or an MDS. However, when we have a very high one and the MCV is large, we will be thinking of things like megaloblastic anemia or still an MDS. Sometimes we could have a falsely reduced MCV, especially when we have red cell fragments, or we could have a falsely elevated MCV. And that is why examination of morphology is always important. And if we have examined the morphology, another quality check that a clinician could do is a rule of 3, trying to look at the HP and the PCV. And we know that the PCV is usually about 3 times the HB. Then you have to look at other parameters that are produced by the autoanalyzers, vis-a-vis the white cells and the platelets, and see whether his diagnosis can be tied along with this. Now, the final things are the advanced parameters that are produced, maybe reticulocytes, nucleated red cells, all this will be looked at. Now, sometimes when we have, like in thalassemia, we could have a very high red cell count and a very low MCV. Those are things that clinicians can look in the presence of a low HP, and I'm seeing a very high red blood cell count. It is suggestive that there might be a thalassemia. One other thing that we could easily do is the Mensa index, dividing the MCV by the red blood cell count. And this can also help us to differentiate thalassemias from iron deficiency anemia. So when you have this index greater than 14, it is more suggestive of an iron deficiency anemia. Now, the reticulocyte analysis. This is one of the things that most of the analyzers now give us. Many of us are used to just looking at the retic count and we stop there. But we know that this can give us a false analysis of how the bone marrow is actually functioning, because it will count both the old retics and the new retics. And that is why we will, normally when you just have the retic count, we will do a calculation which we call the retic reproduction index. However, the new autoanalyzers, which now give us the immature reticulocyte fraction, gives us the same, a picture similar to what we will have gotten from the retic reproduction index, and tells us the number of immature retic, which is a function of how much the marrow is responding to the anemia. Now, these are also one of the newer things that we can see, which is called the reticulocyte hemoglobin content. This measures the hemoglobin in the reticulocyte, and it's the reflection of the amount of hemoglobinization that is occurring in maturing erythroid precursors. And this gives us an indication of functional iron, and we can use it to determine iron deficiency erythropoiesis even before a full-blown iron deficiency has developed. So these are one of the advantages that we get from the newer autoanalyzers. Some autoanalyzers will give you what you call percentage hypochromia, which is also helpful in screening for iron deficiency. And when we have values greater than 10% of hypochromic cells in all the red blood cells, it is highly suggestive of iron deficiency anemia. Then we have the red blood cell quantification. As we all know, with many of the older analyzers, and when we were doing a manual, we always have to count the nucleated and do a corrected WBC count. With the SF cube, for instance, this has been avoided, and the nucleated red cells just comes in amongst the differentials. And this is very important in diagnosis of hemolytic anemia. It's also important in neonatal cell counting, because many a times neonates have high nucleated red blood cell, which can be accidentally or falsely calculated as white blood cells in this population of people. So let's look at some things that we should look at in the lab before sending out, or if a histogram is sent to the clinician, there are a few things that we can just glance through and look at. We know that this histogram, actually, the curve of the platelet should hit the baseline, and then the red cell curve should start. So when this curve does not meet the baseline, it is saying that, you remember that the cell sizes are, in almost all the techniques, are counted by impedance techniques, which is just looking at the volume of the cells. So if we have platelets, giant platelets, or platelet clumps or aggregates, which will now have a larger size, it will be counted. It can be miscounted as platelets or very small red cells. And so you will have this curve will not be able to read the baseline, because you will now have a continuum of cells with different sizes. And that could also occur when we have fragmented red cells. So when we see this in the histogram, we should look at this and look at the blood film to confirm. Sometimes it's the ending of a curve that does not meet the baseline. And the possible causes in these cases are things like cold agglutinin, red blood cells agglutination, and rouleau formation. And then sometimes we have a double peak, which is what we usually will call in morphology a dimorphic picture. And it might be that the patient has been transfused, so we're seeing two populations of cells, or the patient has been given some iron replacement and there is recovery. Hence, we're seeing pneumocytic cells and microcytic cells. Sometimes extreme leukocytosis could also present with such a picture. Now, we've looked at the red cells quickly. We'll also want to look at our platelets. We are all used to having platelet count, and that is almost about all. But with the autoanalyzers, we're having things like mean platelet volume, platelet distribution width, platelet large cell ratio, platelet crypts, optical platelets, immature platelets. And the techniques used are usually either the electrical impedance, which is limited to just size, or the optical light scatter that tries to pick up the granularity and should be more specific to the platelets. So we'll ask ourselves, what are all this and what do we use them for? The mean platelet volume is almost the same thing like the MCV for red cells, just telling us the average volume of the platelets. The platelet distribution width, just like we have the red cell distribution width, tells us the variation in volumes of platelets. We now have the platelet large cell ratio, which tells us the number of, among the platelet cells, how many are actually very large. And this is a sign of immaturity, signs that very large cells are being pushed, which means the marrow is stressed. Sometimes we call them stress reticulocytes are pushed out. A platelet crypt is the same thing as hematocrit, but this time around we're counting platelets. And usually it's about 0.22 to 0.24% thereabout. Then we have the optical platelets, which is based on, in which the platelet counts are counted based on some optical techniques, and then the immature fraction. Now, this is a table that gives us a summary of both the definitions and what they do. So basically additional information we get from the things like platelet crypts and our red cell platelet distribution width, and it's to give us an indication of whether the marrow is functioning or not, and if it is pushing out enough cells. The younger the cells, the more active they are and the larger they are. So when we have a large mean cell volume, it is an indication that immature cells are being pushed out. And usually we'll see this in thrombocytopenic patients. So this just gives us a summary of what all this red cell platelet indices could be used. So just as we have a histogram in the red cell, we also have a histogram in the platelets. And we could also have a multiple peak as we had in the red cells. And this also tells us that either platelets, anisocytosis, or a patient might be recovering from chemotherapy. So we'll see a lot of large platelets, or that there is the presence of platelet aggregation. Sometimes we could also see that the platelet curve does not touch the baseline. And possible causes are either your high blank value, or we have cell fragments, or a high number of bacterials, contaminated reagents, or even aggregates can give us this. So application of WBC. This we have said as we were looking at the technological advancements, because one of the greatest use of the technological advancements were in white cell differentiation. And we had moved from a 3-pack to a 5-pack, and finally a 7-pack. So this table just tells us the 3-pack, as we have said. This is just looking through what we said when we're looking at the technological advancements. The 3-pack was based solely on electric impedance, which gave us just size and volume. But most of the 5-packs used either flow cytometry as an additional or volume conductivity using the RF or fluorescence, as we saw, fluorescent dyes as we saw earlier. And we could now, with the 5-pack, we could differentiate at least the neutrophils, the lymphocytes, the eosinophils, and the monocytes. With the newer ones, we are now able to enumerate the nucleated red blood cells. We're able to differentiate them from white cell count right from beginning without having to do any other maneuver. So in conclusion, cellular morphological analysis is a fundamental part of any hematological laboratory. We cannot do without it. Yes, current analyzers are able to count cells, are able to do WBC differentials with much more efficiency. We're able to detect atypical cells, immature precursors, as you shall see in the next presentation, nucleated cells, so many other things. This has led to improved efficiency and quality of reports, and eventually a reduction in cost. However, regardless of these advantages, evaluation of the results by a clinically professional person, a clinical laboratory professional, is still essential. It tells us that no matter how well technology goes through, all the results still has to be evaluated and verified by a clinical laboratory professional. Thank you.
Thank you very much indeed, Dr. Anne Ogbenna. That was a very brilliant presentation. As has been announced earlier on, if you have any questions for any of the presenters, kindly indicate the questions in the chat box. They will be taken care of, and the attention of the presenter will be called during the question and answers period to attend to the question. Thank you. We will now go ahead to take the second presentation by Dr. Hong Chung Wang, who will be speaking on the topic, the application of monitoring immature granulocytes in clinical practice. Dr. Wang is an associate director of the Department of Clinical Laboratory in Kilu Hospital of Shandong University. He's also a member of the Youth Committee of Chinese Society of Laboratory Medicine, as well as a member of the Youth Committee of Laboratory Medicine Committee of Chinese Society for Integrative Medicine. So it's my pleasure and privilege to invite to speak to us Dr. Hong Chung Wang. You are welcome, Dr. Wang.
Thank you. Thank you. Thank you, Dr. Okara, for the kind introduction. And thanks for having me here. And thanks, Dr. Anne, for giving us an excellent presentation. I learned a lot. And now let's start it. So I'm very happy to have the opportunity to share with you some practice in my work. Today, I'd like to talk about immature granulocytes and the clinical application when they appear in peripheral blood, especially after the auto analyzer can identify and qualify it. So let's first give a brief introduction to immature granulocytes. And In the second part, I'll share some cases to further explain the clinical application when they appear in peripheral blood. Granulocytes originate from hematopoietic stem cells under the action of colony-stimulating factors. Granulocytes progenitors differentiate into myeloblasts. Myeloblasts develop into promyelocytes, myelocytes, metmyelocytes, bound granulocytes, and segmented granulocytes in sequence. This process takes about 10 days in the bone marrow. Mature granulocytes only survive for 6 to 10 hours after entering the blood, and then migrate out of the circulation into tissues at sites of infection, damage, or inflammation. The partition between the marrow storage pool, the circulating neutrophils, and the marginal pool is in constant flux. Myeloblasts, promyelocyte, myelocyte, metmyelocyte are all immature granulocytes. If immature granulocytes are significantly increased, it represents either a reactive phenomenon or myeloid malignancy. We all know that in acute leukemia, blasts and promyelocytes will increase, which indicates that the maturation of granulocytes are blocked. In acute or severe infections, the body's demand for granulocytes increases sharply, and leukocytes will be released into the peripheral blood urgently. This includes both the emergency release from the marginal pool and some granulocytes that are not yet fully mature. The appearance of immature granulocytes in the peripheral blood is meaningful for clinical diagnosis, monitoring of disease such as hematological disease, inflammation, infectious disease, and sepsis. And it is also important parameters for prognosis. Autoanalyzers can provide an accurate measurement of the total leukocyte count and the relatively accurate differential count of neutrophils, monocytes, eosinophils, basophils, and lymphocytes. But they were unable to recognize abnormal cell types for a long time. So a wide differential usually was performed by direct counting of blood film, but it is time-consuming and laborious. Since a smaller number of cells are counted, the error of this measurement is far larger than the automatic differentials. It also requires relatively high requirements on the professionalism of the staff and the consistency between different employees. Now, as we have learned from Dr. An, the autoanalyzer have further developed and are able to report the absolute number of immature granulocytes. At present, immature granulocytes can be recognized on a variety of autoanalyzers, such as Beckman Quarter, Sysmex, and Abbott analyzers. Mindray analyzer also can do that. It adopts laser scattering combined with fluorescent dyeing to recognize immature granulocytes. The immature cells contain a great deal of nucleic acid, the content of which decreases as the cell gets mature. Therefore, normal cells and immature cells can be differentiated by detecting the content of nucleic acid in cells. So let's look at the difference in the intensity of the fluorescence signal of different cells. The cells are treated with a hemolytic agent and then stained with fluorescence dyes. The fluorescence intensity of atypical lymphocytes and immature granulocytes is stronger than that of white blood cells. So we can identify immature granulocytes from mature white blood cells and make a quantitative report. We all know that originally it's 3 differential based on the principle of quarter was used in auto analyzers. Later, after combining the scatter light signals, 5 differential were realized. We have learned that from Dr. An. And now combined with the fluorescent staining, the cells are placed in a 3-dimensional image to identify various abnormal cells. The current analyzers already have excellent abnormal cell recognition functions, including report mature granulocytes as a routine report.
Raise hand if you want to ask question. Then if you want to chat box.
The forward step reflects the size of the cell and the size of the cell. Black
this one is if you want to ask question, raise your hand.
But
once you want to speak, you have to click on this
which
space.
reflects the nucleic acid content. The 3 technologies were combined to identify the immature granulocytes. Look at this 3-dimensional image. Immature granulocyte is large, complex particles, and high fluorescent intensity. They gathered in the upper right of the 3-dimensional model. The mind-ray analyzer reports the number and the percentage of immature granulocytes and give a flag. Okay, next I'll show you some cases to explain the clinical application of immature granulocytes in peripheral blood. When immature granulocytes is detected in peripheral blood, the first thing we have to think of is a hematological disease or infection. There are other conditions that can also occur, such as tumors, acute poisoning, and acute blood loss. Okay, is there? Okay. This patient's CBC shows that white blood cell is increased, and the proportion of immature granulocyte is 20. Let's say immature granulocytes is 21.5%. And the scattergram shows the high fluorescent area of immature granulocyte. I pointed with thin red arrow. The flag on the left alarms immature granulocytes. We found that the patient's myelocytes and metamyelocytes were increased. The final diagnosis was chronic myelogenous leukemia. The number of circulating mature and immature granulocytes can be markedly increased in the peripheral blood of CML patients. The spectrum of cells in circulation closely resembles the maturation sequence of the myelocyte lineage in the marrow. Most of these cells are mature granulocytes, although metamyelocytes, myelocytes, promyelocytes, and even a few blasts may be observed. Basophils usually increase, sometimes reaching to 10 to 20%. Some CML patients, like this one, may also show an impressive eosinophilia, although this is not diagnostically specific. CML patients may first be detected from a routine CBC because of non-specific symptoms. The blood cell analyzer prompts the increase of immature granulocytes, which has a good prompting effect. Okay, the second case, the routine CBC report showed that white blood cell is increased, and the scattergram shows abnormal classification with the alarm flags. I'll put an arrow here, and there may be blast, atypical lymphocytes, and immature granulocytes. We'd better look at the blood smear with our eyes. The smear shows that the promyelocytes were significantly increased, is 86%. We also know that the initial diagnosis was acute promyelocytic leukemia. Later, a bone marrow aspirate was performed, and it was diagnosed as a relapse of acute promyelocytic leukemia. By the way, the patient, the patient has a thrombocytopenia. The platelet is very low. The patient should be evaluated for coagulopathy. This process is very important in patients with APL. And many of these patients present with ongoing DIC and a severe bleeding tendency. This patient was diagnosed with acute myelomonocytic leukemia. During the treatment of the patient, the CBC report showed that the immature granulocyte was increased, and it also suggested that there were blasts. A morphological evaluation of peripheral blood is needed. The results of the blood smear showed that there were immature granulocytes and monocytes, even blasts. Chemotherapy of AML can be divided into several phases. Most of three of them: remission, induction, consolidation, and maintenance. During the treatment of the leukemia, routine CBC is generally performed because when the patient relapses, the prognosis is poor. Immature granulocytes appear in the peripheral blood can be used to monitor the treatment effect and relapse. A leukemia reaction often is associated with infection, inflammation, or malignancy. We once met a liver cancer patient whose CBC results showed an increase in immature granular size during a hospital stay. Have a look at the report. The proportion of immature granular size is high. Left shift, immature granular size and blast flag. Let's perform a blood smear to see what is going on. The smear reveals the presence of immature granular size, but no blasts were found. We all know that the left shift would be found during infection, and it was confirmed that the patient did have an infection. As we all know, myeloid cells may be sort of having three basic functions. The first is the ability to migrate out of the circulation into tissues, as signs of infection, damage, or inflammation. Just now we just talked about the three several. What happens that? Let's talk about the next. What's that one? Okay. So let's continue. And so severe infection or inflammation is associated with an increased release of immature granular size into circulation. So this is a chronic obstructive pulmonary patient. The blood test showed increased white blood cells, increased neutrophils, and immature granular size flag. The ratio was what the immature granular size 14.2%. Okay, we need a blood film. So immature granular size can be seen on the peripheral blood film and left shift, suggesting the possibility of infection. We know that when COPD gets worse suddenly, it is often associated with co-infection. Later, the result of patient's microbial culture confirmed that the patient had an acute infection. Actually, there are more and more discussion on the value of immature granular size in the diagnosis of infection. For example, in this article, assessment of immature granular size percentage to predict severe bacterial infection. The results show that the addition of immature granular size percentage to traditionally used markers of serious bacterial infections, such as the white blood cells and CRP, may help to identify children with serious bacterial infections. So with the in-depth study of immature granular size, it is found that it can not only indicate infectious disease, but also has important reference significance in the diagnosis of sepsis patients. And this article believes that the percentage of immature granular size can be used as a new indicator of sepsis diagnosis. We know that in sepsis identification, PCT, CRP, interleukin-6, TNF, etc., all have important reference value. This article shows that the immature granular size less than 2% are helpful on the exclusion of sepsis diagnosis with a very high specificity. As early as 2013, scholars reported that the immature granulocyte count can distinguish between infected and non-infected patients. Even better than the commonly used CRP, interleukin 6, and other indicators. These related discussion and studies were inseparable from the progress of immature granulocyte detection methods. We have recognized that the appearance of immature granulocytes in peripheral blood has an important prompting effect on many diseases for a long time. We have talked some of them, hematological malignancy, bacterial infection, and there are other situations like inflammatory disorders, acute transplant rejection, surgical, sterile use, and pregnancy, etc. However, only blood film can be used to find the immature granulocyte before, which is laborious and has bad repeatability and consistency between different operators. Now, the autoanalyzers are able to detect them in peripheral blood without any extra sampling and costs. As we can say, instrumental method for detecting immature granulocytes is simple, accurate, sensitive, with good reproducibility, and the new clinical application is constantly being discovered. Okay, that's my sharing. Thank you very much for your attention, and sorry for that interruption. And I hope you have found this helpful. If you have any question, there'll be some time for discussion later. Thank you.
One, we appreciate the brilliant presentation.
Thank you.
We will now have the third presentation, clinical research in hematology of Mindray IVD division. And that will be taken by Dr. Henry Huang, who is a professor of oncology and chief medical officer of Mindray. He's also an adjunct professor of oncology in the Department of Surgical Oncology at Roswell Park Comprehensive Cancer Center in Buffalo, New York, in the US. So it's my pleasure and privilege to invite Dr. Henry Huang to give this presentation. Dr. Huang, you are welcome.
Thank you very much, Dr. O'Kara, for the introduction. And I'm glad today I see you guys, Dr. and Abiola and Dr. Wang from China too. Now we have two speakers presented their excellent presentation talking about hematology, the new technology in clinical practice, and also mentioning about how the instrument analyzer can perform the identification of different abnormalities in clinical practice. So I think this information is very important and is very practical in guiding our clinical diagnosis and the treatment of hematology malignancies. Now, my topic today is I'm gonna share my briefly talk about how Mindray is conducting our clinical study, clinical research in the IVD division. Since the time limit, I'm gonna talk about only the research in the division of hematology, not all the division from our IVD department. So let's see why we do a clinical study, because right now we have a lot of product lines in the IVD department division of Mindray. Because we want to produce a higher and higher quality instruments and analyze to meet the customer needs requirement, and also we want to collaborate with the clinicians, with the laboratory personnel worldwide. So we want to do a lot of things. Want to generate a very good, very high quality of products to meet the requirements of our customer globally. So right now, first of all, I would like to introduce some kind of major product lines from our IVD department division. We have hematology product lines. You can see here a very big one, especially equipped in China in all large hospitals. I would say most, maybe 90%, and all large hospitals in China, big laboratory here, and also in some big hospitals and or laboratories in South America and in Europe, like in Italy and in France, in Europe, in Russia. And we have chemistry product line. We have, can move this thing. We have immunology product line, which is called chemiluminescence immunoassay. Somewhere else. And we have coagulation product lines. We have microbiology product lines. We have urinary product lines. And we also have, a long time ago, we have flow cytometry and also hemoglobin analyzer. Right now, we are developing many products of molecular related. Since last year, we announced a huge development of the total laboratory automation TLA assembling line, which is showing here. You can see it's very large, and we call it all-in-one. Everything is on this line. So for the major large hospitals, laboratories who can afford, and also who have a lot of sample volumes to demand this kind of equipment. So everything is on this line. So you can do a lot of things here, basically just using the whole total laboratory automation system from Mindray here. We call it as M6000. Just like what I mentioned previously, the reason we conduct a clinical study is because the global healthcare demand is very high right now. People want to have a high quality in of life, and for hospital, for laboratory, they need high quality and very fast equipment analyzer. So this drive all kind of IVD manufacturers industry to facilitate their ability to meet this demand. Also, people expect more and more in quality of life. Yes, I just mentioned, and also the science is advancing very fast right now. We know every day is different in science. technology. They move on, develop very fast. So if you don't catch up, you will fall behind other people. So, and also another topic is a very hot topic right now. The artificial intelligence, AI, is at the focus and challenge us very much. So we feel like very stressful and a lot of pressure on us. So that's why we have to do a lot of clinical study to meet this demand from the world. So the purpose of our clinical study is we want to develop new products from conceptions. For example, we got a clue and a hint from a physician, clinical personnel, staff, technologists, and then we want to concept this if it's applicable. If we want to develop this kind of machine instrument, and then if it is good, it's usable in clinical practice. So we need to verify it. We need to put it into action to make sure it's good. So the second thing we want to do it because is when we have a product before marketing, so we need to verify our product quality, and also even if when our products is already in the market, so we still need to expand our products capability, and also we want to solve some issues, some problems, even with the high end of top manufacturers in the world. They still have product problems after launching to the market. So okay. Now, I want to share some clinical studies in the IVD division of Mindray Corporation. These are some of the activities, not limited to here, but too many. So I would say more than 30 right now ongoing. So I just list some as an examples here for you. We do new parameters in hematologic analysis. We create new analytical methods in platelet disorders. For example, platelet agglutination, just as mentioned by Dr. Ann Abiola. And also for low count platelet evaluation and platelet new parameters and functional studies, etc. We are also doing recheck rules, generating recheck rules in hematologic analysis and intelligent recheck. And we also conducting the research in auto verification system in hematologic analysis, and also the new parameters of erythrocytes in anemia. And we also perform algorithm and infection parameters index by hematological analysis, just as mentioned by Dr. Wang previously. Also, we are conducting a clinical study, and this is very interesting and very challenging in the microbes in body fluids in cancer patients to by using this instrument analyzer to identify these microbes in this kind of body fluids. Also, we want to we have done already, finished already the quality assurance in multi-analyzer assembling lines, because a lot of large hospital laboratories in China here, they use more than 10 analyzer in the line from Mindray Hematology. So we want to make sure if individual machine functioning very well and also produce same quality of the results. So we have to do the verification of this kind of multi-analyzers assembling. So This has been done in a large hospital in Beijing. Okay, and then a lot more. So now I'm showing you some examples. I think this case is already presented by Dr. Wang previously, that the analyzer identify some kind of immature cells in peripheral blood, for example, in leukemia. So this machine is very smart right now. You don't need to calculate or to identify by yourself, and the machine automatically identify it. So and then just flagging, and then in the window, and then you check the window, you see the flagging there, flashing, and then you check the parameters, the result from here, this panel as well. You see, as I highlighted here, as red, as blue colors. So you see, and what kind of what next step you are going to do, you know that. So just like Dr. Wang presented, you perform peripheral blood smear, and then look at this slide under microscope, and then you identify the immature cell, abnormal cell. Another example is here. Actually, it's an excellent job by our researcher, our engineer at Mindray. Here they have developed a very good technique to identify the immature red blood cell. We call it nucleated red blood cell. And you look at the histogram and also the scattergram here of the red blood cell and platelet. You know what kind of things happening or going on in these patients. And then you see this kind of abnormal window histogram, scattergram, and you know there are many identical. I'm sorry. We call it as initial cytosis happen in this patient. So we check the smear, and then you see many fragmented red blood cell here showing up in this smear, and then you can see some large cell, red cell. So we call it a macrocyte. So and also you can see some kind of like a teardrop cell here, and a lot of different shape and morphology of the red blood cell. Another thing is just like Dr. Ann Ambiola mentioned about the so-called thrombocytopenia generated by a fake, a false phenomenon in the clinical by the clumping of the platelets. So right now, Mindray has a new technology which is called SF cube technology, can solve this kind of problem. If you don't aware this problem, it could be the consequence. It could be very serious and costly. Okay, you may get a lawsuit. You may face the life loss of patients. So that's very bad. So for this technology, you can see Mindray developed a very good technology. So the sample is warmed up to 42 degrees by the machine automatically, and then the machine add some kind of dissociation reagent into the blood sample, and then the machine automatically vortex, and then in the end detect and then give out a true value of the platelet number. Stuck. And this is another cartoon image of the technique of technology. So I won't elaborate it. And now the last case I would like to share with you, which I think is very exciting. And also this case was presented to some group from Russia. So they were very excited too after seeing my presentation. This was a case with a 36 years old, very young person who got a car accident and then was hospitalized in a large hospital in Shenzhen here in China. So by looking at the parameters from laboratory, and we see a lot of abnormal things happening, and we realize that it's very serious situation for this patient. And also the doctor prescribed some kind of antibiotics for him based on laboratory microbiology testing, and also performed the CT scan for his brain, and also chest X-ray for his lung, and then here you see the technology from Mindray, which develops some kind of inflammatory index indicators here, which reflects very well, very consistent with the patient's situation after antibiotics treatment. And you can see by looking at these parameters, you know the response from the antibiotics as well. So here we have temperature, we have WBC, we have PCT, which is procalcitonin. We have CRP, which is a C-reactive protein. We have some kind of neutrophil, nucleic acid substance content. We have monocytes, volume distribution, with all kind of this sort of things all together, and reflect the patient situation with the response of antibiotics treatment. So you can see here, when all of these parameters going down, means the patient's reaction response to antibiotics was well, and also when you see all of these parameters went up, so that means the patient's condition is worsening from clinical relevance. So this is very exciting. Actually, we are observing more patients right now. I know they have done more than 30,000 cases so far. And also, as a parallel cross-examination, we have checked the morphology of the cells, neutrophil and monocytes, alongside with these parameters I just described. So they are very consistent, and in the end, unfortunately, the patient died. So because of too severe infection, and also the damage to his brain. So it's unfortunate. These are my presentation today, sharing with you some clinical study research at Mindray in the department, in the division of hematology. And we also have many events. We call it as International Hematalk in Hematology Forum. And we have done a lot of activities already, events, webinars, and meetings, etc., in different countries. And these are in Thailand, and these are in Philippines, and these are in the headquarters of Mindray in Shenzhen here, China. So all of the people here attending to our meeting are very happy. You can see the face here, and we talk to each other, and then they are happy here. You can tell from their face, and they enjoy the tour to large hospitals in China to meet, to communicate with their the peers in China. So that's all for my talk today. Thank you very much.
Thank you very much indeed, Dr. Huang, for that brilliant presentation. We will, I hope participants are taking notes. As earlier mentioned, any questions you have, you just indicate in the chat box, they will be distributed to the appropriate speaker. We'll be having our last speaker now, last but not the least, Mr. Kelechi Ekwonwa, who is the IVD product specialist of Mindre. He's a medical laboratory scientist. He will be presenting on Mindre high-end hematology solutions. So it's my pleasure and privilege to invite Mr. Kelechi Ekwonwa to speak on the topic, Mindre high-end hematology solutions. You are welcome, Kelechi. Kelechi, are you there?
Yes, can you all hear me?
Yes, please.
Okay, good. Thank you very much, Dr. Kara, for the introduction. Warm appreciation to the erudite resource personnel that have already presented brilliant papers. Thank you, Dr. Ann, Dr. Juan, and Dr. Henry. Much appreciation. Hello, everyone. Thank you very much for joining this webinar. My name is Kelechi Kenneth Ekwonwa. I'm the product specialist for Mindre. I will be presenting on Mindre high-end hematology solutions that provides technology and innovation that enables core labs and hospitals deliver quality healthcare. So let's dive into it. Okay, Mindre hematology portfolio as we diverse and provides for all categories of labs and hospitals depending on lab test volume. Of course, the hospital's focus is actually ranging from primary care hospitals to core laboratories, including university hospitals. From the slide, you can see we have both 3-part analyzer, 5-part analyzers. Dr. Ann had actually done a very good job in trying to also, give us backgrounds of, why it's called 3 parts and why it's called 5 parts. May I also add also that our 5-part analyzer actually, accommodate reticulocyte and nucleated red blood cell. Next slide. Our market performance has been globally recognized, hence having Mindre Hematology being among top 3 brands globally. The global appeal of Mindre Hematology innovation has resulted in having more than 800 cellular analysis automation line already installed across the globe. We have more than 16,000 5-part analyzer installs. Also, the best performing hematology analyzer across all brands is Mindre 3-part analyzer, with a huge milestone of having more than 188,000 units that has already been installed worldwide. As you can see, Mindre is actually, a brand that the world over had actually recognized. Our high-end hematology family envisions high clinical value for all labs, especially core labs and secondary or tertiary hospitals. Now, if your lab experiences high false positive ratio or inaccurate platelet results, or perhaps your lab usually receives good number of reticulocytes and body fluid testing requests, then your lab needs one of these robust and pocket-friendly hematology workhorse. We have BC 6000, BC 6200, and BC 6800 plus. We also have a cellular automation line that we call CAL 6000, which is our new generation benchtop hematology automation line capable of up to 220 tests per hour. It comprises of BC 6000 or BC 6200 in addition to our slide maker in a configuration already predefined. Also, we have another automation line which we call CAL 8000 Of course, Cal 8000 is an intelligent and highly optimized workstation capable of 200 to 800 tests per hour, depending on the configuration of the BCC 800 plus analyzers configured on it. It's usually a standalone modular system. Mindray Hematology high-end solutions add clinically significant value by offering the best parameter performance in the industry, having 37 hematology reportable parameters and 48 research parameters. Furthermore, our BCC 800 plus gives 14 hematology flags. Of course, these flags actually help our esteemed clinicians to be able to manage their clients and patients professionally. I know that Dr. Henry and Dr. Ann had actually made mention of this. SF Cube technology is actually an innovative technology that has been patented by Mindray. It actually focuses on blood cell analysis for reticulocytes, nucleated red blood cells, WBC 5-part differentiations with effective flagging of abnormal cells such as immature cells, like Dr. Henry and Dr. Huan have actually made mention of. Also, red blood cell fragments and lipid particles also have been found, have been also enumerated by this SF Cube technology so as to minimize interference of lipid particles in your assessment of your CBC. It achieves this by a combination of laser scatter and fluorescein technology, in addition to having a 3D display of information. As highlighted on the fourth slide earlier, the SF Cube innovative technology enables our high-end solutions to give a more accurate, corrected WBC result. In fact, I heard during the presentation of Dr. Henry, someone asked a question about this issue of corrected WBC. So as you can see, our high-end hematology analyzer actually gives a more accurate corrected WBC by ensuring that nucleated red blood cells are fully characterized, enumerated, and of course excluded from that, so as not to give a erroneous result. Also, reticulocyte characterization and enumeration helps our clinician to better manage anemic conditions, as we can see on the slide. Cases of thrombocytopenic challenges are resolved by Mindray multifold counting capability. Of course, for platelets, we have a capability of 8 times counting so that you can get an accurate, reproducible result for cases of thrombocytopenic conditions. Also, the same technology also helps in giving accurate WBC results in leukopenic conditions, by making sure that the multifold counting capacity is actually done 3 times for WBC so that you'll be able to get an accurate result, despite low levels of WBC that is actually in the sample. Also, parameters like INR, both absolute and percentage, as already expatiated by Dr. Ann earlier, is also available on our Mindray Hematology high end, and it assists in malaria flagging and screening. So this can be a great pointer for hospitals and labs to actually flag in for malaria testing for cases of patients that the clinician or the doctor did not request for malaria test. All Mindray Hematology high-end solutions are enabled with an intelligent software we call Lab Expert. This software is a standard configuration of the BC6000 series for professional data analysis. It automatically sorts out the suspected samples for further validation and recheck based on predefined validation rules. This software enables BC6000 series to be more powerful, more efficient, and of course, smarter and represent more value for the end user. Now, Dr. Ann and Dr. Huang also made mention of pseudo thrombocytopenic conditions. We in the medical profession, we know that this particular case has always been a huge problem because it has, in many cases, it has led to false cancellation of surgeries just because of this situation. Hence, negatively impacting on patient outcomes. Mindray Hematology High-End is equipped with platelets automatic deaggregation technology. This technology adopts isothermal deaggregation techniques that ensures that platelet count is always correct. This is reflected in our optical platelet capability of BC6000 series, as we can see on the slide. Mindray Hematology solutions played and are continuing to play key role in the fight against COVID-19 pandemic by ensuring that our analyzers have parameters such as CRP, neutrophil to lymphocyte ratios, PCT, and the rest of that, which are key prognostic trackers for the COVID-19 pandemic. These parameters follow predictable pattern during the COVID-19 sequelae. So one of our machines also that actually espouse these parameters is actually BC5390 CRP. This is actually a composite analyzer that actually gives you the NLR, of course, along with your CRP test results, in addition to CBC, as we can see on the slide. Mindray played a crucial role in the fight to combat COVID-19, both in China and around the world. In China, Wuhan Husheshin Hospital was built in 10 days. Amazing, to tackle COVID-19. Of course, they built that over more than 33,000 square meters of land space, of course, which accommodated 1,000 beds, 30 ICU centers, and of course, operated by more than 1,400 doctors and nurses. Around the world, Mindray Total Lab solutions like our cellular automation line series have always continued to play a key role in managing the pandemic. Now, let's look at our Mindray Global reference sites. DASA Lab Group is in Brazil, is one of many Mindray Global reference sites. This group is the 5th largest medical diagnostics in the world and still retains the largest medical diagnostics in Latin America. Currently, they run about 321 branches or labs, and of course run more than 10 million tests per month. With an annual revenue of about $1.1 billion, of course, being run by over 18,000 employees. This group has 8 units of CAL 8000 of Mindray, about 32 units of BC6000 series. This shows that Mindray Hematology High-End is a trusted partner of DASA Group, as we can see on this slide. Another good Mindray reference site is Centre Hospitalier de Libourne. This hospital is the biggest public hospital in Libourne, France, processing about 250 to 300 tests per day. Our CAL 8000 series is in this lab. The configuration of that CAL 8000 that is there is actually, captured as 210. This 210 means 2 units of BC6800 plus 1 unit of our slide maker. And we have enjoyed a great partnership with this hospital in France. Of course, let's look at West African region. Of course, there's no way we can, talk about the rest of the world without also mentioning that of West Africa, where we actually belong. Mindray brand enjoys huge partnership among the medical community in Nigeria and Ghana. Let's look at the reference sites in both countries. In Nigeria, Evercare Hospital Lekki, which I'm sure that the staff of Evercare Hospital are also logged on to this webinar. That hospital is the top private multi-specialist hospital in Nigeria. Our Mindray BC6800 is fully functional in Evercare Hospital as we speak. In Ghana, Mindray has 2 units of BC6800, 1 unit of BC5800, 1 unit of BC 5380 in the largest hospital in West Africa. And of course, the third largest hospital in Africa. The name of the hospital, as we all know, as we can see also, is Kolebu Teaching Hospital. Let me also use the opportunity to still remind us that the vision of Mindray is actually focused on better healthcare for all. How do we achieve this better healthcare for all? We do that through our mission by advancing medical technologies to make healthcare more accessible. I want to thank you very much for listening. I will wait for your question where necessary. Thank you very much.
Thank you very much indeed, Mr. Kelechi Ekwowa. Let me appreciate the very widespread participation of colleagues. I can see quite a number of participants from across the West African region. I even saw one from outside West Africa. It is really, really interesting and very commendable. And I must also place on record our deep appreciation and gratitude to Mindray. You have continued to make the work in the laboratory a pleasure by coming up with this wide array of technology-driven equipment, keeping up to date, even to the point of making parameters for the management of COVID-19 available in your platforms. It is really commendable, and we do urge you to keep it up and keep making cutting-edge technology and knowledge that make the work in the lab and in the hospital really easy and a pleasure. Thank you very much indeed. It has been my pleasure and privilege to host the platform.